Thanks very much, and thank you to the organizers for inviting me to this important, interesting, and very stimulating meeting. I'm really pleased to be here. You'll observe that the title of my talk is different to that given in the program. I'm not going to be talking about WHO's attempts to measure non-injury or non-mortality consequences of conflict at all. Not because they're unimportant, but precisely the opposite, because they are so extremely important, and because we as yet don't really know how to do it properly, and it would therefore be premature for me to try and say anything about it. The longer one looks at such health consequences, the more one learns about their very long-range effects over many decades after exposure to the kind of adversities that happen in situations of conflict and war. So, instead of doing that, I'm going to focus a little bit of my talk on interpersonal violence, in other words, homicide in this instance, as well as collective violence. And you'll see why. At the outset, though, I can tell you that I'm from the Department of Violence and Injury Prevention and Disability, and in our department we focus upon the prevention of interpersonal violence rather than conflict-related violence. Deborah this morning mentioned another department which sounds like a cough, HAC, Health Action in Crisis. They are the group in WHO that work in conflict settings such as DRC. I'm also speaking on behalf of a colleague of mine from the team that works on mortality and burden of disease estimates, Dr. Colin Mathers. He unfortunately can't be here today, but is really the author of much of the talk. So in a sense, I'm speaking on his behalf. In the time that I've got, I'm going to try and do 5 things. First of all, I'll review the WHO typology of violence and give you a quick glance at some of the current global estimates of deaths due to violence. Then I'll look at sources of information with a focus on vital registration systems and the WHO mortality database. Third, I'll illustrate the measurement of violence using data from vital registration systems. Then I'll review WHO efforts to estimate the global burden of violence with a focus on deaths due to collective violence and the use of mortality surveys, very controversial area. And I'll conclude with recommendations about how we might improve the ability to count and estimate deaths due to violence, or improve our ability to advocate for and to pressurize governments, international development partners in improving the situation. Starting with the typology of violence, I'm not sure how many of you are familiar with the 2002 World Report on Violence and Health. In that report, for the first time, a typology that is increasingly universally adopted was presented, a typology of violence that breaks it into 3 large subgroups: self-directed violence such as suicide and self-harm, interpersonal violence such as youth violence, intimate partner violence, sexual assault, and collective violence, what we're talking about here, conflict, structural violence, and so forth. This categorization of violence maps very closely onto the international classification of disease approaches to categorizing injury deaths, of course very purposefully. International classification of disease, the ICD system, is the universal approach to classifying diseases and injuries, and certainly WHO advocates for its universal uptake. What is very interesting, and I think Paul mentioned it, is that external cause codes for injuries are surprisingly absent from both developed and developing country health information systems. You've got a few more countries which actually code the actual nature of the injury, concussion, penetrating wound, etc. But even there are relatively few countries that actually allocate codes to fatal and non-fatal cases that come with injuries. And this is perplexing to us, not really perplexing, we understand violence and injury haven't been addressed as preventable problems until perhaps the last decade. And people therefore haven't seen the point of allocating codes to these conditions in the same way that they do to measles or whooping cough, etc. However, should they start allocating codes, then the prevention benefits will be considerable. Also, it doesn't cost very much to identify an injury. You don't need laboratory procedures. It's very cheap. It's probably one of the cheapest things to definitively diagnose. Anyway, so the ICD categorization of injuries and causes looks like this, which very much coincides with the typology of violence. To give an overview of what, according to the WHO estimates, violent deaths looked like in the year 2004, they looked like this. Self-directed violence, by far the largest, the majority of cases, about 840,000. Interpersonal violence or homicide, about 600,000, 36%, and then collective violence, one of many estimates, 180,000. This obviously is an estimate. It's the global burden of disease estimate. But I'd like to encourage you to critically reflect upon how your work here in relation to conflict-related violence can benefit these other very prevalent types of interpersonal and self-directed violence too. This morning I was thinking about the situation in urban areas affected by conflict, what happens afterwards. I'm thinking about surveys when in refugee camps of patterns of interpersonal violence within refugee camps, often intriguingly similar to the kind of patterns of violence in the places from which those refugees came. So some really interesting work to be done on the interplay between these different types of violence. No surprise, 90% of violence-related deaths occur in low and middle-income countries. When you look at injury deaths by age, you can see that violence-related deaths load on the 15 to 29 and 30 to 44 year age groups, where you see suicide and homicide right up there in the top 10. The other 120,000 deaths, according to the estimates, come in the 30 to 44 age group and the 45 to 59 year age group in terms of the collective deaths that aren't on this chart. What's important is to also look at where the other external causes, the other injury causes, road traffic injuries, drowning, burns, see how they relate very closely to these, at least in terms of the age groups most affected. And that's also something to bear in mind, that when we are doing efforts to prevent violence, we should also be looking at other external causes. There may be common risk factors and common approaches to prevention. Certainly in terms of trauma care and victim assistance, there are commonalities.